And I just would like to thank Dr. Gupta and Dr. Nag for their generous invitation, and also to Praveen, who's been a wonderful host today since I arrived this morning. And so we're going to just touch on the issue of management in early breast cancer. Here we go. So in terms of where we are and the treatment paradigm, we have a very clear treatment paradigm at the moment with early breast cancer. If patients have a small tumour, so up to a T1C, no nodal involvement, these patients will go for surgery, and if there's nothing new discovered at surgery, many of them will go on and receive trastuzumab with paclitaxel alone, followed by completing a year of trastuzumab. If it turns out that they were node positive, and this doesn't happen very often, we're pretty good at figuring out which patients need to start with neoadjuvant therapy. I don't often see any more patients who have gone for upfront surgery who we then discover had node positive disease. They would need chemotherapy with Herceptin and pertuzumab. In the patients who we think need to go for neoadjuvant therapy, and the patients that go for neoadjuvant therapies will be patients who have a tumour, depending if you go by which study criteria, above 2 to 2.5 centimetres or node positive. They will then receive 4 to 6 cycles of neoadjuvant chemotherapy with pertuzumab and trastuzumab. In the past, that was more cycles of therapy, but we'll discuss that in a moment. They'll then go for surgery. If they have residual disease, they'll then complete a year of TDM1. And if they've had a complete pathologic response, they'll continue with their pertuzumab and Herceptin until they've completed a year of treatment. And really the backbone of managing any breast cancer patient, but particularly the management of backbone in HER2-positive breast cancer, is the multidisciplinary care. And I think the shift into neoadjuvant therapies has really almost imposed upon us that the multidisciplinary care is not just when we're deliberating about something, but really it's a tool that we need to use for each and every one of our breast cancer patients to ensure that we're making the best decisions of their care, together with our surgeons in a very clear partnership, along with the other members of the MDT team, which would be, beyond the surgeons, the radiation oncologists, pathologists, radiologists, geneticists, and of course our nursing care, who we probably couldn't do any of this without. And in our centre, we also have our psychosocial care coming into this and giving their input about our patients who are more complicated. In terms of updates in early breast cancer, not a lot of significant updates. This last year, there are updates about long-term outcome for the Affinity study. So in the Affinity study, we now have a follow-up of 8.4 years, and this was published in the Annals of Oncology this year. In fact, at the end of this year, end of 2022, it was published. So we are all familiar with that study. It was a study that looked at adding pertuzumab to Herceptin and chemotherapy for patients with HER2-positive breast cancer. And very early on, it became apparent that the benefit was limited to those with node-positive disease, which made sense. We're seeing the benefit in those who are at higher risk of recurrence. And over time, this benefit has been consistent. It was originally seen to be as an approximately 2% benefit, later grew to approximately 4% benefit, and now we see a difference of approximately just under 5%. And this is clinically meaningful as well as statistically significant, but more important, it's clinically meaningful. In terms of overall survival, so these are results after 8.4 years, and although the hazard ratio here includes 1, this did not meet the testing for statistical significance. The difference here was just under 2%, but did not meet pre-required statistical significance. But we are seeing a definite disease-free survival benefit for the node-positive groups. I will just add that people forget with the Affinity study, it was not an easy study to recruit for because we had already made a paradigm shift to the neoadjuvant group. So we did not have very high-risk patients in the Affinity study. We did not have patients with big, bulky breast disease, and we didn't really have patients with big, bulky nodal disease. So I think we need to be careful when we interpret those results because I think there is a slight underestimation because of the bias of who was entered into that study. So I think there is a probably underestimation of how much the benefit existed for the node-positive patients. This is a final analysis from the phase 3 Peony study. This is a study that looked at neoadjuvant pertuzumab in addition to chemotherapy and Herceptin. This is an important study that I'm mentioning, and I'm just going to stop for a moment on. It's a study performed in the Asian population. We know from many studies that often because of pharmacogenomics or pharmacogenetics, there are different toxicity profiles within the Asian population or different populations in general. I don't think in breast cancer we've seen big differences in efficacy between drugs because of pharmacogenomics. We've certainly seen differences in toxicity. And so this was an important study to see the ongoing results of. And here we can see this now has a median follow-up of 5 years. And in terms of event-free survival, we can see that there was a significant benefit for those that received pertuzumab, both at 3 years and 5 years. And this is really an 11% difference at 5 years. That's really quite significant. And in terms of disease-free survival, we're seeing the same numbers as well. In terms of overall survival, this has not reached clinical significance, but I would argue that we probably need a little bit more time as we have a mixed bag with patients. Usually half of them are hormone positive, and we know that for patients who are HER2 positive and hormone positive, we really need to look at overall survival results as we head towards 8 to 10 years. There weren't any significant notable cardiac events, which was important to note. And in terms of serious adverse events reported, we didn't see anything unusual that we did not know before. And in terms of diarrhea, which is a real problem that we're all familiar with, giving taxanes with Herceptin and Perjeta, it was significantly higher with the addition of the pertuzumab. But I think that's something that we have learned to manage with time, although I'd be very interested to hear from the panel's experience how well they find or how easily they find it to manage. It can be a little bit challenging. The other study, which was not from this last year, but I think it's important to mention it because it was practice changing, and I actually think it was practice changing for 2 reasons. The first reason are the results. This was the TRAIN study. The TRAIN study looked at a protocol of TCHP or a protocol that had FEC followed by HP, and also they also received taxanes, and this was really to look at, can we give a protocol without an anthracycline so we can protect the patient's hearts more, reduce any risks of any potential leukemias or MDS in the future. And what this study saw was that in terms of pathologic complete response, the results were identical also for the arm that did not receive anthracyclines. I do have colleagues that are still reluctant to not give anthracyclines if it's a very high-risk patient, so like a T4 and 3. But I think this is really, I don't know what's happened here in India, but in Israel this has really brought around to a big change in our practice, and most of our patients are getting TCHP. I will comment that I actually think the TCHP is more difficult than ACTHP, but the patients come in less. And this is the other reason I think that this has been a success, because these results came out during COVID. And in COVID, we were trying to keep our patients out of the hospital as much as possible. And compared to, for example, ACTHP, where the patients need to come in 16 times, with the TCHP, the patients only needed to come in 6 times. So I think that the change because of the COVID, the timing with the COVID, also brought around this change and the adoption of the non-anthracycline regimens. So what more can we do for our patients with patient care in HER2-positive breast cancer? So obviously there are ongoing studies looking at new agents. I assume that in some of your centres you might be involved in some of the clinical studies looking at the comparison of trastuzumab deruxtecan with TDM1 in a clinical trial setting for those who have residual disease. But at the moment there isn't anything in the immediate period that's going to change how we manage these patients. Is neratinib used in India? No, it's not available. So neratinib is a TKI inhibitor, and we do have access to it, and we use it in Israel in patients who are hormone positive, who had significant nodal involvement at diagnosis with residual disease following standard care, and we can give that to them after they complete their year of TDM1. But other than that, we are limited with what we can do. So one of the things that Roche has really been innovative about, they did this with Herceptin and now they've done this both with Herceptin and pertuzumab, is shifting us from IV infusions over to subcutaneous infusions. So IV infusions are burdensome on the system. Pertuzumab takes anywhere between 30 to 60 minutes. The patients usually need to be observed afterwards, at least for initial dosages or when they're getting a loading dose. And trastuzumab also is at least a half-hour infusion. How do we best use our resources? So the subcutaneous formulation is very quick to prepare. We don't need the pharmacy to prepare it. It can help with patients who have problems with venous access, particularly now if we have shifted over to TCHP, where we need to get venous access for 6 doses of chemo, no longer 16 weeks with ACTHP. So these are patients who we can try and help avoid having to put in a portacat or a PICC line, depending on what your centre of practice is. And for some of these patients, this is really important. Many of the patients find the IV poking around very traumatic for them. So I think this is a really important issue. So how has Roche been able to do this? So they have a unique technology where they take their drug and they incorporate it with a recombinant human hyaluronidase, and that actually helps open up the space under the epidermis, and actually allows for the material to be, or the drug to be injected. It takes about 5 minutes once a nurse has had proper training to inject it, and it's absorbed fairly quickly, and the patients seem to tolerate it very well. And here, the effect of the hyaluronidase are reversible, and the permeability of subcutaneous tissue is restored within 24 to 48 hours. So we always want to make sure that if we have a new formulation of a drug, whether it's a new formulation, whether it's a biosimilar, are we going to get the same pharmacokinetics, efficacy, and safety? And so this is the Federica study. The Federica study looked at incorporating subcutaneous Phesgo, which is the combination of pertuzumab and Herceptin, and the patients changed from the IV formulation at one point over to a subcutaneous formulation. And what we can see is that in terms of primary endpoint, which is looking at the pharmacokinetics, we can see that there was no difference between the IV group and the subcutaneous group. You might argue that the subcutaneous group has better pharmacokinetics, but there was no statistical difference between the arms. And we can see this in both cases. When we look at efficacy, because efficacy is something that certainly worries us always, we can see that in terms of pathologic complete response, the results and the outcome were identical between the intravenous and the subcutaneous arm. When we look at it in terms of upper body mass index, because sometimes we worry when it comes to body mass index, are we underdosing our patients? If we give them a subcutaneous injection, are they getting the same pharmacokinetics and pharmacodynamics as a patient who is obese? And this is an issue because I think in all of our countries we are facing an obesity epidemic, and this is going to impact how we manage our patients, including how they respond to treatments and how we dose them. So it was interesting to see here that at least in patients who were either obese, overweight, or normal weight, there was no differences. There was a slight difference in patients who are underweight, but as you can see by the numbers here, we do not have a dearth of patients who are underweight. In terms of the safety profile, there were no differences between the IV and subcutaneous arm in terms of adverse events or serious adverse events, and certainly no difference in issues of death or discontinuation. Maybe there was slightly high discontinuation for the IV arm. So we can see that in terms of PK and efficacy and safety, we have similar results. So this study in summary showed that the subcutaneous formulation was non-inferior to pertuzumab and trastuzumab IV. This was going from cycle 7 onwards in this study. And also in terms of serum trough concentration. So this is important. There's no difference in efficacy, and the safety profile was comparable between the two arms. I will just say that this really supports the HANA study. For those of you who recall the HANA study was also a Roche study looking at IV Herceptin compared to subcutaneous Herceptin. It was really a proof of concept study, and we can see that this is repeating itself, and this for me is important because it means that we can repeat this type of approach, and we can see that the results are reproducible for this concept of the changed formulation. So what do our patients prefer? So in this study, they assessed what patient preference was. The strong majority of patients prefer a subcutaneous regimen. So this was like over 90% of patients. Why do they prefer subcutaneous regimen? Well, there's less time in the clinic. It's more comfortable during administration, and the majority of patients chose to continue with the subcutaneous formulation once they had started. What's the perspective of the healthcare professional? Because that's also important, because if we have a formulation or a method of treatment that is not convenient for the healthcare professionals, particularly the nursing staff, it will not be used. That's the bottom line. If physicians or nurses are not comfortable with a formulation or a drug, it is very difficult to administer it and use it in clinical practice. So the healthcare professionals were very satisfied with the use of the subcutaneous formulation, and it didn't seem to have any impact on doctor-patient communication. So often doctors and nurses are short of time. They want to know this is not going to take them more time with their patients than what they already have. And I think this is an important thing to note about the issue of communication. In terms of preparation time, the difference between preparation time in our drug rooms is a difference of 15 to 20 minutes to 5 minutes. So that's it's a quarter of our team's time. And in the treatment room, it is much shorter. So in the treatment room, Herceptin Perjeta will take at least an hour if somebody's really fast, and if we're already at the point where we don't need to supervise the patients. Whereas with the Phesgo, this here says a bit longer, but I can say that it's basically 5 minutes. It's very quick. And what we have actually done at our hospital is we developed a fast track afternoon, and we have an afternoon where patients who are getting subcutaneous formulations of Herceptin, of Phesgo, of denosumab, or short infusions of Zemira, they come in, and in one afternoon we get a lot of patients taken care of, and it's excellent both for the satisfaction of the nursing team, but it's very good for patient satisfaction as well. They know that they're going to come in and it's going to be quick and it's not going to be disruptive. In addition, at least in Israel, in some of the community settings, the patients are able to receive the Phesgo near their home. It's not always possible because the nurses, is not a regular subcutaneous injection. The nurses need to have special training in how to administer the injection. In terms of the safety, in terms of injection sites, there were more injection site reactions with the Phesgo, which is something we would probably anticipate because it's a local skin response. I think it's worth noting that there was less diarrhea in patients who got the subcutaneous formulation. That's really important for our patients. Otherwise, in terms of fatigue and other side effects, it was very similar. So this just summarises about patient satisfaction, about the perception and the experience of the healthcare professionals in terms of use of resources and time impact in the clinic, and the safety data, which is completely reassuring. There were no untoward signals whatsoever. So if I just summarise the barriers and the benefits of subcutaneous formulations in general. For the patient, what might be a barrier to uptake? So the patients are already getting ongoing IV therapy. Some patients prefer to keep going. If they've already had to have a port or a PICC line put in, then many of them are not going to want to change over to a subcutaneous formulation. Some patients are fearful of a subcutaneous formulation. It's important to be aware of that, not always intuitive. And some patients have a perception that getting a drug in their vein is more effective than getting a subcutaneous. Very hard to educate people about fixed beliefs, and particularly when the beliefs are wrong. But for those who have a fixed belief, it's very hard to shift them. In terms of the healthcare providers, the patient's already on ongoing IV therapy, they're just comfortable. We need to specially train the nursing staff, so that can be a barrier. In some countries, remuneration is different. So I don't know how it works in India, but particularly in some Eastern European countries, remuneration is different if the patient receives a drug intravenously than if they receive a drug in any other type of formulation. So that can also impact whether a healthcare provider is going to use a new drug. And in terms of remuneration, there are countries and there are hospital settings which don't feel comfortable with a shift of patient care to the community setting. So I actually think that maybe in a setting like India, where not all patients live near a big centre, if there was a way for them to get their subcutaneous formulation in the community setting, that would probably be a wonderful thing. I can tell you that in Israel there are fights between the hospitals and our HMOs because our hospitals do not want those injections given by the HMOs in the community because they want the remuneration. I always tell my patients they should get it where they want because we need to take care of what's in their best interest. And even amongst healthcare providers, there are misconceptions about efficacy of IV and subcutaneous formulations. In my previous hospital that I worked in, the head of the daycare adamantly refused to let us give subcutaneous Herceptin until I was in a position where I was able to overrule her. And she was convinced that we did not have enough data. And she was not the only one in the country, so sometimes overcoming misconceptions by healthcare providers is difficult. The benefits are clear. We avoid IV, it's fast, it can be given in the community, there's less time spent in the hospital. This was a major benefit during the COVID crisis. Another reason there was a lot of uptake of this formulation. And for us as healthcare providers, it's efficient, it's better use of our staffing, of our resources, our pharmacy and our time. And again, the COVID crisis, this was very helpful for. So if we just go to our treatment algorithm, our patients are very fortunate today. I remember what I used to think when I saw a HER2-positive breast cancer patient 20 years ago when I started my residency, and we used to think, oh no, this is terrible. They're going to have a recurrence and brain metastases very quickly. And then Herceptin entered the market in the year 2000. And today our patients have a plethora of options, both in the early setting where we have learned how we can de-escalate, to the patients with more advanced disease, where we know which patients need some escalation, but if they have a complete response, we don't need to keep escalating, and knowing who needs further escalation if they have residual disease with TDM1. And now we also have the option of the Phesgo to help improve our patients' quality of life. I will add one more word about the Phesgo and then I will finish up. And that in our metastatic breast cancer patients, which I haven't discussed, we get incredible feedback from our patients, because those who complete 6 months of a taxane with the Herceptin Perjeta and then move over to a subcutaneous regimen when they're not getting the chemotherapy anymore, many of them feel very good, and many of them say to me, it makes me feel like I'm a healthy woman again. And I think to hear that sentence from our patients is very rewarding and has incredible importance for our patients. So I thank you for your attention, and thank you once again for inviting me to participate with you.